Dr. ELLENBOGENOM, thank you very much for joining us during this Zoom call. You are the experts in vitro fertilization and in reproductive health. And of course, I have lots of questions because the fertility is of great concern for many families in Kazakhstan. And I think it's very important that we have sufficient knowledge about that. So I have several questions I'd like to ask, and if you please answer to those. So in vitro fertilization, which called IVF, has helped millions of couples to conceive, but success rates can vary widely depending on factors like age and fertility issues. So Dr. ELLENBOGENOM, what are the recent advances are being made to improve IVF success rate, and how do these innovations impact the patient experience?
Yeah, thank you. This is indeed a very important question. I want to show you this slide, and this is very important slide because you see it's actually the results that you have from 2019 from the British authorities. And indeed, first of all, the fertilization rate after in vitro fertilization depend mainly on the age of the patient, of the woman, and of course also about the cases of infertility. And you can see that in 2019, about 32% of women under 35 could be pregnant, will become pregnant after IVF. And you see those results drop dramatically to women that are over 40 to 11%, 5% or 4%. And what is more interestingly, it's what actually happened during the years. You see, in 1992, for instance, a woman low, that her age was low to 35, the percentage age was about 8%, and today it's about 30%. And again, you see the same figures increase with the increase of the age. Even today, if you can say to a woman that she's 43 or 44, that she has about 5% success rate, is dramatically increased from what we had in 1992. And those are actually the latest results from Israel, that what we call take-home baby, and this is actually what is the most important thing, the take-home baby of a woman that is less than 35 years in Israel in 2021, the census that actually we have obtained from all the IVF units that we have in Israel. And by the way, we have about 37 units, and we are performing about more than 40,000 cycles of IVF a year. You see the delivery rate, the live birth rate was 45% on the women that are low to 35, 31, 35 to 37, 29, 38 to 39, 33%, 40 to 42, and 4.7% between 43 and 44. So you can see that during the year it was indeed and absolutely increasing success rate. And to answer your question, actually this was caused from several developments. First, improvement of stimulation protocols. Second, the introduction in 1992 of ICSI, intracytoplasmatic sperm injection, that actually revolutionized all the procedures that were done according to male infertility to azoospermic, mainly to azoospermic male. Third, improvements in laboratory procedures. Four, that is very important, at least in my view, patients-oriented treatments, and also genetics and artificial intelligence, that we'll talk about that later. This is the famous picture of Bob and Louise Brown, that she was the first IVF baby that was born in 1972 from a natural cycle. And the natural cycle was a cycle obtained from fertilization of only one particular egg. And this was the problem, because the problem is to obtain high pregnancy rate when we came from a natural cycle, obtain only one egg, so the possibility was very low. So during the year, actually we developed treatments, mainly gonadotropin treatments. But the problem with the gonadotropin treatments, that the issue were to obtain more eggs. The problems was that was premature ovulation and the loss of cycle actually were non-successful. So in about 1980, the long protocol was introduced that actually make a revolution in our understanding and our capability to obtain more follicle, more eggs, more embryos, and then actually to increase the pregnancy rate. And after 8-10 years later, the antagonist protocol was introduced that actually simplifies the protocol or the treatment that we can offer to the women, and other protocols that were afterwards developed, and different other medications that were introduced, like letrozole plus gonadotropins plus antagonist protocol, and so on, that actually also give a possibility also to increase the pregnancy rate to those patients that were what we call poor responder to the treatment. And we can see here actually the long versus the antagonist, the long agonist versus antagonist protocol. And this is the old protocol that actually was mainly trying at the beginning, after about 2 weeks of stimulation with a GnRH agonist, to make desensitization of the pituitary to avoid premature ovulation, and then to add the gonadotropin for the stimulation of the cycle. And then lately, the agonist protocol that actually make desensitization immediately, so we can actually shorten the treatment and actually obtain the same pregnancy rate. But indeed, the pregnancy rate was tremendously increased comparing to previous year when gonadotropin or, of course, natural cycle were used. Now, what about improvement in laboratory procedures? First, we improved culture medium. New culture medium were developed in order to obtain better fertilization, higher fertilization rate, and mainly higher possibility to culture good or suitable embryos for transfer. And lately, the embryoscope, that is actually a kind of, let's say, I can say that like a computer that can visualize absolutely daily, every 10 minutes, the development of the embryo without actually putting in connection with the surrounding air. And indeed, it was shown that the pregnancy rate in those units that introduced the embryoscope, and I think that now most of the units, at least in Israel and in other countries that I know, from England, for instance, United States, I think that about 90% of all the embryos are cultured in this kind of machine. And of course, the future, and I think that we'll talk about later, of new technologies, like embryo real-time metabolism assessment, that actually can assess the metabolism of the embryo from the culture media, and to see indeed what are the best embryo that are producing the best metabolites and the best embryo to be cultured and transfer. And lately, and we'll talk also about that, about non-invasive PGTA, non-invasive genetic assessment of the embryos that actually possible make us feasible to obtain the best egg from the genetical point of view, indeed to increase, maybe to increase the pregnancy rate, but indeed we shall talk about this issue later. And I think that all those procedures actually increase dramatically the pregnancy rate, and it's possible that in the future will increase more the pregnancy rate, but will never reach 100%, of course. And maybe with the introducing with artificial intelligence, that they will talk about that issue also later.
Thank you, Dr. Ellemboghen. So apparently you showed the picture of Dr. Edwards and his first baby was born in the tube. It's been quite a while since this happened, but still IVF is a relatively new procedure. And I assume maybe hundreds of thousands, maybe millions of children were born using this method. So what are the potential safety issues? How safe is the procedure? What are the potential problems when these children grew up? Are there any health issues? And how reproductive doctors usually deal with those potential risk factors? Thank you.
Indeed, I want to show you one more figure before I answer to this question. And I leave it from the last, because in my opinion, in my humble opinion, one also of the very important part of the success, and also it actually connect us with your question about the future of the embryos. It's patients-oriented treatment. And when I mean patients-oriented treatment, I mean actually to give the proper treatment to the proper patients and to explain in very, very details also the possibility that will have an increase in maybe malformation, in maybe other problem that we'll discuss in a moment. So it's very important to keep healthy weight, to maintain blood sugar level, but very important to reduce stress level. And this is so important, our talk, our explanation, our feeling that the patient will understand properly what we are doing and what will be the results of our doing, that can actually increase the success rate. And there are some places that there are different kind of, let's say, the supplements for IVF that can increase actually the chances, as for instance, vitamin D supplements, different vitamins, and even acupuncture. And talking about your last question about mental, genetic, and physical health of children born, that is such an important issue that should be discussed very, very deeply with our patients. And why are we taking that? Because just looking to these figures, we have more than 6 million children that were born between 1991 and 2016. And you are looking to the figures from 2020 in the United States, about 80,000 live born after IVF were obtained. And that is about 2% of all the deliveries in the United States. And they can say that in Israel, that figure is even higher. We have about 4% of all our deliveries actually is delivered after in vitro fertilization treatment. So indeed, this question is so important, and we know that, and we know from the literature, and we know from our experience, that actually assisted reproductive technology is associated with a small, what is called OR 1.3 increase in birth defect. The question is if the birth defects are due to the procedures that we are performing. It means laboratory media, maybe intracytoplasmatic sperm injection, or is the original cause of infertility. We actually do not know. But we also have to remind the patients that the normal increase in birth defect is about 2 to 3% in the natural cycle, compared to 3 to 4% in ART. So we have to communicate this data to our patients, but this increase is not dramatically, at least not now, and not in the, and we'll talk about in a minute, not now when you actually improve mainly our culture media and our technique to perform in vitro fertilization. And you are looking to these figures that are very interesting. You see, looking here about growth, height, and the hearing, vision, there are no difference between IVF children and the natural conception children. Childhood illness, more or less the same. You can see that hospital admission, more or less the same. There is such an increase in neurological disease, we shall talk about that later, and such some increase in childhood cancer. And also we'll talk about that a little bit later. So except that, not other parameters were dramatically increased in IVF versus natural conception cycle. This is a very nice study, I think from 1921 or 1920, about psychological development of full-term singleton born after PGTA at preschool age and family functioning, and to us a prospective case control study of more than 100,000 children born after IVF compared to natural conception, and there were no difference detected between the psychological development in those children that passed IVF compared to ICSI children or natural conception group. And not only that, what was more interestingly, that the parents of the children did not differ in reporting problem behavior. So the behavior of the children at home or at school actually was the same as children born after natural conception. And this is very, very important to say. I mentioned neoplasm. And about neoplasm, you can see if you are looking to brain, adrenal, urinary, lymphoma, leukemia, hemangioma, maybe except secondary or what we call urinary, and urinary I mean mainly hypospadia after ICSI procedures. Comparing in vitro fertilization to natural spontaneous cycle, and it was 2,600 patients after in vitro versus more than 200,000 spontaneous cycle, there are no differences, no statistically significant differences. But with looking to this figure, that is even more important, that is a study of more than 1 million children that born to fertile women, 80,000 with, and about 1,000,000 without a major birth defect. In children born after IVF and after spontaneous cycle, you can see that fertile children, children that was born in natural conception cycle, had 1.7 cancer rate per 10,000 cases versus 2.3 of children born after IVF without birth defect. But when a birth defect was observed in IVF children, indeed the percentage of the cancer rate was increased from 5.7 to 16%. So actually you have to take care of mainly of those children born after IVF and have a malformation, observed malformation. But no, this is the question. The question is that now when you are performing so many studies during the pregnancy, mainly after pregnancy obtained after IVF, we can observe this observation, and majority of the people, and I'm saying majority because are people from different religious groups that are not permitted, but you can terminate the pregnancies and not obtain a malformed children to be delivered. But nevertheless, we can say that it is some increase, and we have to follow those children that they were born after IVF. And the only thing that we can see today that those results are retrospectively children born after procedures that were performed at least 5 to 10 years ago. And when, again, as we said at the beginning, that we improve our culture milieu, that we improve our technique, it's possible that these figures will positively change in the future. I think that I have something final conclusion. And of course, we have to communicate all these results to our patients, mainly about the possibility of hypospadia after ICSI.
Yeah, thank you, Dr. Ellebogen. One of the potential and actually frequent outcomes of IVF is multiple pregnancies. Like, like I often see that women deliver triplets and even more. Many families are very happy with that. And for instance, I'm a godfather of 3 beautiful kids who were born by IVF, and the family is extremely happy. But at the same time, those multiple pregnancies may pose certain risks during the delivery, especially for women who are of older age. So how do you deal with that? How you address to this potential issue for some families? Thank you.
I would like to start my answer to a question. What is the pregnancy, the twins rate delivered after IVF in Kazakhstan?
I really don't know. So we need to ask our friend, Dr. Lakshin.
Look, I'll tell you why I'm asking that, because now in Israel, you see, we have absolutely strict regulation, and those regulation actually applied, I think, since 4 or 5 years ago. So our pregnancy, twin or multiple pregnancy rate decreased dramatically in the last 5 years. And the twins pregnancy rate in 2020-21 was no more than between 1.5 to 2%, no more. And why? Because actually we have the regulation that I detailed in this slide. And the regulations are very strict. And we the physician, we must apply and must transfer according to those strict regulations. First, single embryo transfer, what you call SET. And there are a lot of publication in the world literature that in a woman that is 30 years or younger, the possibility to obtain a pregnancy between transferring 1 or 2 embryos is the same, but the possibility to have a twin pregnancy is dramatically increased when you are transferring 2. So our regulation is that in a patient with 30 years of age of younger and has a high quality embryo, in the first cycle, we return only 1 embryo. If no pregnancy will be achieved, we'll transfer 2 embryo in the next 2 to 3 cycles. So this is first. If a patient, actually the cause of infertility is a male factor, azoospermia, or non-obstructive azoospermia to a patient that underwent a genetic diagnosis, we can, on this special case, transfer from the first cycle 2 embryos, and of course, to be very, let's say, very specific in telling the patients about the chances of obtaining a multiple pregnancy of twin pregnancy, but of course, no more than 2. When you can transfer more than 2, and actually it's 3 circumstances. A, after 3 treatments, after up to 2 embryos were returned without achieving pregnancy. So you can transfer 2 or even 3. In a woman that is 35 years old or more, after 2 repeated IVF failure, and that the woman age is over 40, we also can start to transfer 3 cycles from the first cycle for the first IVF attempt, but in no case, no more than 4. And actually, I never in the last several years, I do not remember a case or an IVF treatment that we actually transfer 4 embryos. So those are the regulation, and according to those regulation, we decrease dramatically the multiple pregnancy rate, and of course also of the twin pregnancy. And I think that it's very important to apply those regulations all over the world in order to decrease this problem that is actually a problem. It's a big problem. Indeed, a patient likes to have twins, but she's likely to have twins before she became pregnant. After the delivery and unfortunately, when you have premature deliveries, and this is one of the biggest problems, I think that we have to explain that you will think differently.
Thank you. Obviously, there are certain genetic risks in not only natural pregnancy, but also IVF implantation. And lately, many clinics try to utilize genetic testing prior to implantation. So how useful and how successful this method, and what are the implications, any impediments or any issues related to genetic testing? And specifically, what are the ethical concerns with genetic procedures?
This is an excellent question and difficult answer. And the excellent question is because we know that today, the age of the women, and you'll see that also the age of the male partner, it's increasing. And we know that increased age can cause more increased case of aneuploidity of the embryo. And of course, we also know that according to the age, that it decrease, as we said before, of pregnancy rate. So definitely we thought that we'll develop an excellent tool in order to check the euploidity or the normal chromosome number of an embryo, what we call the post-gestational aneuploidity testing, or testing of aneuploidity. And actually, there were very special and new methods to test those, and there are a lot of publications which method is better, is comparative genomic hybridization, next generation sequencing, NGS, that is very popular, at least in my country, copy number variant. So actually what we are trying to do is just to retrieve naturally now from a blastocyst, from a tracheoctodem, some cells, and to obtain their genetic status. It seems excellent. So we know, okay, we'll obtain a positive results. Positive, I mean genetically problem or genetically ill embryo will not transfer. It will transfer only embryos that are genetically normal. It's not so simple, because we know and we obtain that there are a lot of limitation of PGTA, or what we called before that PGS. And we found, and there are several results, several reports, that we show that the concordance rates from the same cells that were obtained from the one blastocyst were different. So we biopsy twice, we test the first cells and we obtain one result, and we test the second set of tests and obtain different results. So it's a problem. So it could be caused what we call the mosaicism, that it's quite common in the blastocyst. Second, it was been reported that in about 1/3 of the repeated sample from the same cell, from the same blastocyst, it was found an abnormal result from the first, from the same cells. And the second test performed on the same cells were obtained a normal results. But much more, when abnormal fetuses, when we obtain an abnormal results, and we told them to the patients, and they decided that those abnormal embryos will be transferred, and we obtain healthy children. That is what we call the false positive results. And inversely, when a woman become pregnant after transfer of normal embryos after the PGTA, and the pregnancy ended in a miscarriage, and we check and we biopsy the cells from the miscarriage, about 1/3 of fetuses were not normal. So it's what we call the false negative results. And even more, it was just in 2022 in January, in fertility and sterility was a study of 2 randomized that were published, in which they showed that there was no advantage, not under the age of 35, neither in the woman over 35, on the pregnancy rate obtained after PGTA. And another study also showed that even we biopsied 1 blastocyst, and they have only 1 blastocyst, versus pregnancy that were obtained after normal laboratory checking, embryoscope and morphological and so on, it was a decrease in pregnancy rate on those women that undergone transfer of the PGTA blastocyst. So we thought today that the PGTA, or what we called before PGS, it's not reliable enough, and it should not be offered to patients routinely. But there are some patients that are saying, okay, I am old, I'm 42, I want to be absolutely sure that my embryo that you will transfer will be normal. So we will transfer this embryo, so-called normal embryos. And also in those cases, we have to explain very deeply that it's not in state of pre-pregnancy genetic screening or during pregnancy genetic screenings, what is called CVS or amniocentesis. So in conclusion, we are performing that. We have to be very careful in explanation the results and explanation the limitation of PGTA of today. It's possible that in the future, something will change.
Thank you. Now about the future, about science. So in vitro gametogenesis, it's called IVG, is an emerging technology. It actually allows for creation of sperm and eggs from adult cells, such as skin cells, and this obviously potentially revolutionize fertility treatments. So how close are we with this new IVG technology? It sounds like science fiction. And so what are the potential benefits, and are there any ethical concerns with this new technology?
It's something revolutionary. We mentioned science fiction. I think that in our days, nothing is science fiction, because what was science fiction, let's say 10 years ago, today is a fact. So we have to look with open eyes to the results and continue to search for the future, maybe for the early future, and to improve the results. And you can see that the IVG, in vitro gametogenesis, included various approaches, trying to culture new gamete from embryonic stem cells. And by the way, we had a study that we published several years ago that we were able to find embryonic stem cells, or mainly stem cells on the testes of azoospermic people that we biopsied them. And we could culture until, let's say, several stages of spermatogenesis. But we didn't succeed to obtain any embryos. So what we call induced pluripotential stem cells, spermatogonic stem cells, we'll talk about later. And there were several results that actually obtained some impressive results, but in rodent and not in men. One of the possibility and the thought that were at the beginning of this new area is for Mitalipov. Mitalipov, he's from the United States, that actually thought to obtain new gametes in a technical closing to cloning. But the difference of this technique was that we need to make haploidization of the new egg that we obtain. And actually what is done, it was to take off the nucleus from the egg, and to replace from a nucleus from a cell, from a cell of from the same patients, from a cell that what is also a somatic cell, and to make haploidization of the chromosomes, and then to fertilize this new egg with sperm. And it was a study that performed in a mouse, and they obtained about three pups of the mouse. The problem that also in Spain, and you can see here, you know, the procedure, can retrieving the nuclei of the eggs, introducing the nuclei of cells, of the somatic cells, haploidization, fertilization, and then we can obtain make division, and even a blastocyst was obtained. The problem that when other researchers try to perform this technique, they couldn't actually observe the perfect division of the chromosomes, and actually this kind of possibility of obtaining was completely banned, including in Spain, that were very that's thought maybe mainly in EV, they're trying to make such new gamete, but they have to ban because the results were very poor. Lately, Japanese scientists succeeded to expand this technique and to generate human oogonia from induced pluripotential stem cells, but also only in mice. And you know, the thought was that we can obtain from the ovary, mainly from patients that are very poor responders, or even for patients that are in the menopause, to obtain human oogonia stem cells. But unfortunately, it was not possible to obtain. And recently, and I'm talking about a study published several months ago, that was a single cell analysis of human ovarian cortex that were, you know, making slices of the cortex and try to obtain oogonia stem cells, and nothing actually was obtained. So until today, it is in the research area. I couldn't talk about success, not only women, but very poor success also in mice or in rodents. But as I said at the beginning, we are not raising our hands, and we are trying to continue to develop techniques in order to obtain such gametes that indeed could absolutely, definitely improve the problem of poor fertility in many patients. And one more thing about men. I mentioned before the study that we performed about spermatogonic stem cells, and it was actually several studies that resulted in fertilization of mature sperm that were cultured from spermatogonic stem cells and to fertilize ova from mice, but it was not so far obtained in human. And definitely when it would be full realized, IVS, but what is called spermatogonical stem cells spermatogenesis could actually offer a excellent treatment, a treatment for those men with azoospermia, and to reduce the more operations that we are doing today in order to find some sperm cells in those people. So about the second question about the ethics, it's also a problem still, because as you can see here in this slide, and I'm quoted what is in the United States, there are no federal laws that prohibit IVF work, but Congress had banned any research that creates, destroys, or significantly harms human embryo, and they absolutely banned for those researchers to receive federal funds. And at the state levels, laws governing human embryo research varies, with 11 states banning it entirely. And second, we have to continue to develop the IVG. We have to obtain the approval of the Food and Drug Administration, of FDA. And up till today, it is not clear that this agency will approve even such research, starting in pregnancy with embryos that were genetically manipulated. But we have a light. You know, sometimes in a deep tunnel, it's very important to have a small light. And the light is that FDA accepted mitochondrial replacement therapy, also known as 3-person IVF. So it is possible that IVG could fall under the same provision if the somatic DNA and egg came from different people. But if they came from the same person, it might be banned. And something very important about ethics. We are worried about the availability of IVG that could lead in a new area where parents could create large number of embryo, use a genetic tool in order to select the best one. The best one, I mean, let's say only boys, and maybe only girls, and maybe only people with dark hair or whatever. So IVG raises the specter of non-consensual parenthood, something that most country laws are well equipped. We do not know what to do today. So if IVG in summer will become clinically available, those questions will be legitimate. What cells to be used, to which person to use, in what condition to use them, and we will need actually a regulatory answer. And I hope that it will happen in the future, but unfortunately not now.
Yeah, I think I actually wanted to ask about the designer babies, about like genetic manipulation. And you mentioned Dr. Shukrat Mitalipov. He's actually originally from Kazakhstan, works for university.
Really? I didn't know that.
Yeah, he actually very close. He's originally very close from the place where I live. And he frequently visits Kazakhstan, and I think he's a visiting professor in one of the universities, and he helps quite a lot. So he's one of the star scientists here. So thank you. Anyway,
he's the chief director of the very famous unit in the States, and he's dealing a lot with IVG now. And I think that what is very important, because I just mentioned, you know, the technique that actually he continue to try to improve this special technique that I mentioned at the beginning. I think that it's very, very important and very nice. I think that this could be, you know, the light and the end of the tunnel.
Yeah, I actually been to his lab in Portland, Oregon.
Portland,
so
yeah.
We visited his monkey facility. So he's one of the he's doing a lot of good job. So it's a
So you say this is a small world.
Right. Yeah. So of course, these reproductive technologies are aiming mostly to assist families with infertility, but the world population is growing, and according to the United Nations, by 2050, the world will have almost 10 billion population. So what is your take on the use of reproductive technology while overall population of the planet is increasing, but at the same time there are many countries where fertility rate is still very, very low? And I just came back from Sweden, Finland, and Norway, which has the fertility rate below reproduction. The same as some Asian countries such as Japan and South Korea. So what is your take on these issues, and how reproductive technologies may address this?
I think that we are exaggerating. I think that we are exaggerating with figures. And one of the last issue of American Geographic journal, there's a big article: overpopulation, 10 billion of people will be in the end of this year. It's possible, but I think that we are looking to those figures with fear, because looking in more details, we can see that during the, let's say, the past 20 years, it was a decrease of what we call the fertility rate. The total fertility rate. What it means, total fertility rate? This figure means the average number of children that a woman can deliver during her fertility period. And if you're looking to that figures, we can see that between, let's say, 1962 to 2020, it was a decrease of the world average fertility rate from about 5.2 to 2.5. It's dramatically. Looking even to a country like India, the fertility rate decreased from about 4.8 to about 2.6. And as you mentioned, there are countries that the fertility rate is even lower than 1. For instance, in South Korea, the fertility actually it's about 0.73 today. So looking to those figures, we can see that in the next, let's say, about 10 years, that we know that indeed, during to the better medication and better standard and increased standard of living, mainly in the developed country, not in the underdeveloped country, but this is a political issue that I don't want to enter. Indeed, we have less mortality rate, or mortality rate, or it's lower. But in the next 10 years, as I mentioned, we'll reach an equilibrium of the population that will not grow anymore. So we don't have to fear about the 10 billion. And we have to think, and again, I don't want to enter in politics, how we can actually permit lower income country, lower income population, where there the fertility rate is still higher, to preserve better education, better contraception, better understanding, better standard of life. But this is politics, and I don't want to enter this. Looking to the fertility rate, I can say, you know, just from my humble experience, that a person or a couple that are infertile, they do not care about that numbers. They want a child. And they want a child, and doesn't matter in how and with what and with what. So we, as a physician, have to provide the treatment for those couple, and the best treatment that you can provide today, and even better treatment that will provide tomorrow, according to what we just talked about, the future of development of fertility tools that you can reach. So I don't think that we can change anything about the demand of the infertility people to have a child. and you have to provide everything, despite those figures that are not so dramatic.
Yeah, thank you. The world population is not only expanding in some countries, but the world population is aging. So what's the situation with that? And I know that many families, many women of older age want to have babies, and they want to use IVF as a tool to have more babies. So what are the issues and what are the potential risks with that, and how reproductive technology can deal with that?
Just a moment, I want to show you also some slides. Yeah, you are right. You are absolutely right. And we have to take to look about what happened actually in our clinic. And you can see from here that, you know, the age of the female attending, when she's attend a fertility clinic, increased. You see, it was about 29 in 1989, and it was about 32 on 2005, and those figures increase. And also we know that this slide that is known to everybody, that the probability of ongoing pregnancy is decreasing according to age. And also the probability of pregnancy loss is increasing to age. So what we can do, and you can see from here that what you are thinking of unexplained infertility. And there are a lot of people, mainly in the older age that you mentioned, that are what we call unexplained infertility. It means that all the checkout that you are doing, it's absolutely normal. And you can see that people that are over 35, we have a higher percentage and what we called unexplained infertility. That I think that everything that is unexplained, we have to explain. And from here you can see that if about 10% of women that are lower than 35 were diagnosed with what we call unexplained infertility, and this unexplained infertility was due to their age, 97% of women over 45 will be diagnosed with unexplained infertility. But it's not unexplained infertility, it's the age itself that can cause, and I'll show it in a moment. And we know also that increasing age is decreasing the anti-Mullerian hormone rates. That it's one of the tests that now we are performing routinely to see what we call the ovarian performance at any age. So the second thing that also we know, what you mentioned before, that it's also a completely decrease in euploid rate in oocytes according to increasing age. And we know something that is very simple and known to everybody, that increasing age, increasing the possibility to having a Down syndrome baby. So what we can explain, age per self explain infertility. So one of the things that I can give an answer to your question is first that ovarian reserve, so such important, should be evaluated as a part of infertility evaluation that we are not doing routinely today. Even that women that we know that they are young. For instance, AMH just lately was introduced as a routine in some clinics in my country. I don't know as in other countries. So we must make this ovarian reserve evaluation from younger age in order to start proper treatment in appropriate time, and not to leave a patient to mature or to reach older age when actually the treatment will be more difficult. And one of our problem, it's egg freezing. And again, in Israel, it's a tremendous increase because I think proper explanation that we made through the media about the egg freezing, and there are some institutes that are actually founded and about women that actually came to us and asking egg freezing. And just for my, again, humble experience, just in the last 3-4 months, I have at least about 15 patients aged between 30 to 38, 39 that came and asked for egg freezing. And what is interesting, and this is so important, that are couple that are coming for egg freezing. And this is, one of my answer to your question, that are asking for egg freezing and embryo freezing on the same time. So thinking what will happen in the future when this couple will want to deliver another child despite the older age. So this is one of my answer. What about the men? We are sometimes forgetting about the male factor. And this is a very interesting graph that you can see the age, mean percentage of age, when father reaching a pregnancy or starting to want a child, and you can see that the age of the male from different ethnic group definitely increased during the years. That is very interesting. And looking to this slide, that is even more interestingly, on the years between 72, 75, about 4% of men married or wanted children when they were over 40. Today, it's about 9%. Even men that are over 50 were over 50 in 1972, 0.5%. Today it's about 1%. So even the age of the father of the man increased, not only the woman. And this could be also a problem. Why? Because the age of the male partner has a significant impact of reproduction. And sometimes we make a sperm analysis, and maybe we'll have time to talk about that. And we have a normal, so-called normal sperm analysis. But not all the time this so-called normal sperm analysis could properly fertilize. And at this point, the age itself may cause an increase in medical condition, decreased semen quality. And why? Because it is increasing oxidative stress and DNA fragmentation. So this is very important, and maybe we'll have time to talk about the man itself, but we have the couple. And the couple, it's the female that we discuss, the men that we have to concentrate, and we are not concentrating today. Having a normal spermatogenesis, we are thinking that everything is okay, but maybe that it is not.
Yeah, this is actually very important as male infertility accounts for nearly half of all fertility issues in couples, and yet research and treatment options have lagged behind those for women. So mostly everybody concerned about women, but how about men? So what are the recent developments that made to understand and treating male infertility, and how might this advancement change the landscape of general fertility treatment?
This is something that I thought that we're leaving for the end, but okay. I call it the forgotten man. The forgotten man that, during the year, it is something very, very interestingly and frustrating, because all of the years we already thought that only the women had a problem. And we applied a lot of techniques and a lot of thought and a lot of development, trying to understand. And then to improve or to treat women problem, but we didn't think about the men, because the man was some taboo. Maybe that the man itself doesn't wanted actually to start to be, let's say, cancel the machoism, I'm calling that. But lately we started to understand actually the main problem. And the main problem, it's actually what is happening today. And what is actually happening today, that it's mainly due to pollution, to the changing of the lifestyle, so the unhealthy diet, that the sperm quality has declined worldwide in the last 40 years as much as 50 to 60%. So this is a big problem. So actually what we can do, and you're asking just for the men, so I give something about the female, but also for the men. Looking to the sperm analysis, and this is the sperm analysis that they mentioned, we need 1.5 milliliter, normal pH, over 50 million per milliliter, over 30% fast moving, progressive moving, at least the 40% progressive moving, more than 4% strict morphology. But even that we have those figures, sometimes it is not enough. And as you said, med infertility, about 40% of the couple, we observe male infertility. 40%, it's a huge. And what I started to mention, that in the majority of the cases, it is what we call unexplained. We have a normal sperm analysis, So what we can do? First, to change life factors. And you see that there are a lot of life factors that can actually be, let's say, overcome or treated. Obesity, smoking and alcohol consumption, using a lot of laptops, tight underwear, exposure to toxin or heavy metals. By the way, maybe there are some papers from Sweden, that in Sweden, maybe in the south part of Sweden, where the pollution is very, very high, and the industrial factory continue to emit smoke, that is a very, very deep decline in sperm count of the male population on those cities. From Göteborg, for instance. Cell phone usage, drugs, different drugs, mainly opiates that they more and more are using today, even marijuana. So all those life factors could be changed and have a very important part in what we call male infertility. So you have to evaluate. And I'm not entering in detail in evaluation because the time, but you can see here fertility history, sexual history, medical history, development and children history, mainly scrotal injury, torsion, mumps, that we have to know about that, family history, surgical history, vasectomy, surgery, and so on. And the proper examination, size and consistency, vas deferens, varicocele, and so on. Endocrine evaluation and genetic testing. But what is more important, and we are not doing it routinely, it's what we call sperm chromatin, or what we call DNA fragmentation testing. I don't know in which country it is a routine test for any sperm analysis, but here is a results from Denmark that was demonstrated that poor quality sperm chromatin structure were assessed by sperm chromatin structure assay that is highly indicative of male subfertility. It means even in males that have more or less normal sperm analysis, regardless of the number, the motility, and morphology of spermatozoa. Therefore, the DNA fragmentation test, it is relevant, in my opinion, must be one of the routine tests in the normal, what we call normal or routine test evaluation, because what we called actually the possibility of having ROS, reactive oxidatory species that are detrimental for testicular function could actually be demonstrated with this test and treated properly. And the second is sperm infection. Again, we are not making a routine analysis of the spermatic fluid. It means not even a culture. And it was demonstrated that sperm infection, maybe HPV virus infection, could be detrimental for normal fertilization of the egg with a sperm that is normal. And of course, we can improve it, but our newly method, we told about ICSI that was developed in 1992 by Palermo, and it did make a completely revolution of treatment of male infertility, mainly from severe oligospermia and azoospermia in men. And this is a testicular sperm aspiration, testicular sperm extraction, percutaneous sperm aspiration of microscopic epididymal sperm extraction that actually we can obtain few sperms from actually azoospermic, maybe even non-obstructive azoospermic people, and fertilize egg and obtaining a pregnancy. And of course, we are trying to give some what we call now tricycle that are different vitamins that maybe they can improve the quality of the sperm. So all this until we'll actually reach the new development of having maybe artificial gametes or artificial sperm, as we said some minutes ago. I think that this is our highest possibility to offer proper treatment for infertility men.
Thank you, Dr. Ellenbogen. I have a question concerning cancer and fertility, so which is very, very important. So cancer treatments can sometimes lead to infertility, prompting some patients to seek fertility preservation. So we discussed a little bit before the freezing eggs so this is very optional, but it could be very important for preserve fertility function. So what advancements have been made in fertility preservation for cancer patients, and how are those options helping to ensure future family building possibilities in those families in case somebody is diagnosed with cancer? And by the way, there was recently a conference in the capital city of Astana here that dedicated to this very issue.
Yeah, thank you for this question, because indeed it's very important, and we are dealing not with a few patients that unfortunately suffering from cancer disease. And just I try to summarize the American Society of Clinical Oncology and their recommendation of fertility preservation in cancer. And of course, all those kind of treatments or fertility preservation should be discussed with the patient before starting the treatment. And we can talk about adult men, adult women, and young. And about adult men, of course, sperm cryopreservation. And of course, the cryopreservation is strongly recommended that the sperm to be collected before initiation of treatment. Because even our cases that after receiving the treatment, we can observe again that sperm are produced, but we are very worried that the DNA integrity of this new sperm produced after chemical treatment or after radiation treatment will be compromised, and therefore, what I said before should be the best chances. The problem could be, and we'll talk it a little bit later, in children. But let's leave it for in several minutes. In adult women, of course, cryopreservation of embryo, or even today, cryopreservation of oocytes. And today we have very flexible protocol. We have protocol that actually we can start stimulation immediately in the follicular phase, in the mid-follicular phase, in the mid-luteal phase, and obtain development of follicle, and then retrieving eggs and fertilize the eggs if the female has a partner, or actually cryopreserve the eggs itself by vitrification, and the results are excellent. Sometimes we do not have time even to obtain a treatment, because the oncologists are asking to perform their treatment immediately. And then we can actually try mainly in adult women to obtain just very tiny eggs, unmature eggs, and to make in vitro maturation, what is called IVM. And there are papers from Canada that actually they demonstrated that those eggs that were mature in the lab and were frozen, and they were taught they obtained actually excellent eggs to be used after the treatment will finish. So because the time is time of this procedure, it's not longer depend on the menstrual cycle, I think that this is the best opportunity to give for adult women, married or unmarried. Now, ovarian transposition, mainly in those patients that need to receive radiotherapy, and is performed. Actually, we have to remove the ovary or ovarian tissue and to transplant them higher in the abdomen. And actually, several papers were published that after finishing the treatment, those ovaries or even parts of ovaries could be stimulated and obtain mature eggs. About ovarian tissue cryopreservation and transplantation. This is performed today. There are some countries that obtain, after these procedures, live children. Of course, this procedure does not require ovarian stimulation, could be performed immediately, and could be performed even before sexual maturity. And this is very important. So this is the main procedures actually proposed for children that are suffering from cancer. So I think that we also made a tremendous development on this issue in the last years. I know that in my country, ovarian tissue cryopreservation, it's performed in a routinely manner. And also the cryopreservation of embryos or oocytes with stimulation or without ovarian stimulation, it's also performed. So I think that those two items could be very important in explaining the patients to receive their treatment, to wish them to be healthy, and to have the, let's say, a sunny future, Wow. My friend. Hello.
Okay, I don't interrupt you. Okay, you can continue after finishing, like few words.
This is a surprise.
Yeah. Yes, please go ahead.
Now, as I said, this is a procedure that now to preservation of fertility is a procedure that today it's, I think, in any university hospital, with an IVF unit that should be performed absolutely routinely in cases of malignancies. Of course, to protect and to protect pregnancy, to protect the possibility to have children in the future.
Okay, thank you, Dr. Ellembogin. So I have last questions about artificial intelligence. So we all astonished with ChatGPT and those advancements. Sound like we thought this would be future, but apparently we dealing with that currently today. So what is the implication of AI in reproductive technologies, and how do you see the future, how artificial intelligence will change the technology and help families to have more babies and safely deliver babies?
You know, we started our conversation saying that the future it's now, today. So artificial intelligence is the future that it's working today. And not only in the fertility issue, in many, many, many fields. In fertility, there are introduced infertility AI in laboratories. And in one report published recently, that they performed with a computer that actually acts as AI, artificial intelligence, they demonstrated tremendous improvement in obtaining pregnancy rate in comparing to the, let's say, the normal or the daily use of embryologic assessments, even using the embryoscope. And the second thing that they actually obtained, that they demonstrated that artificial intelligence could actually develop normally genetic embryos that, as we said just several minutes ago, PGS could not. So this is the future. In Israel, this is one program introduced that actually introduced in the lab that demonstrated indeed a higher fertilization rate and higher pregnancy rate using the artificial intelligence. So we started slowly to introduce. The problem and everything that is new have to rise ethical problems. And in my opinion, one of the big ethical problems, it will be if not the artificial intelligence in the future will not replace us totally and will actually do things that may be unethical. We do not know. We do not know. We have to take care. I think also, as we said about IVG, we have to make regulation in using the artificial intelligence as soon as possible, because the artificial intelligence, this field is developed tremendously. So be careful, but do it.
Okay. Thank you so much, Dr. Ellenbogen. This was very insightful. So I wish you all the best in all your endeavors in your fabulous work.